meeting of the conference committee on Senate file, what are we, 4410 is our number? Anyway, it's good to have everybody here. And again, sorry for the delay. These are kind of common at this time of the year. And our intention is to go through a few things fairly quickly. So hopefully we'll be able to, the House has the floor, I think, at 3:30. So it doesn't have time to be long, but we weren't intending to go long anyway. So, you know, in the last, recently, the Senate has put forward, put on testimony on their priorities and so on. And, you know, our point has been that there are lots of needs in this state, and we consider a lot of them critically urgent needs. And the House bill is a lot broader than the Senate bill and includes issues that the Senate just didn't include. And so as we go forward, we feel that it's important to be mindful of the needs of all of Minnesota, or at least as much of Minnesota as we possibly can. And especially, I think, in a year when we do have a large budget surplus, I think people expect us to try to deal with some of the problems that are out there. And so we hope to work together to do that just as well as we can, because, you know, one person's need is to them critical. And whether that person is a person with disabilities or a person who desperately needs childcare, or a person who's homeless on the street and needs a place to stay and a way to get back on their feet, or so many other issues, a Minnesotan who can't afford health care, a Minnesotan who's got desperate medical needs and can't afford their prescription drugs. So today we're going to talk a little bit about some of the ways the ways the House bill tries to address some of these other urgent needs. And so with that, I'm going to start by turning the floor over to Chair Schultz, who is going to talk about healthcare costs and refer to our Article 3 of the House bill. So Chair Schultz.
Thank you, Chair Liebling. And I just want to remind the public the state of healthcare coverage in Minnesota, and then talk about our provisions to help address the people who are uninsured and the cost of healthcare. So roughly 4% of the population in Minnesota are uninsured. This is a little over 200,000 individuals, and that's broadly across the whole population. People of color and Native Americans, the rate is much higher at 10.2%. Of non-Hispanic whites, it's much lower at 2.4%. So we still have many, many people across the state that are uninsured. And then second, we have a significant number of people who are what's considered underinsured or functionally uninsured. That means they have inadequate coverage for the healthcare services they need. Things like their premiums are more than 10% of their income, their out-of-pocket costs, excluding premiums, are more than 5% of their income, as well as their deductible being 5% of their income. So any one of those items makes them functionally uninsured or underinsured. So people who need care may not be receiving care because they can't meet the deductible, or they don't have the money to pay for their prescription drugs because their out-of-pocket cost is high. So to address this problem, many people can't buy coverage because the premiums are too high. And what's driving that in this country, driving the high cost of healthcare, are prices of healthcare. So we pay almost twice as much for healthcare per person in this country compared to other developed countries. And that is the problem that our state and other states needs to tackle. And in our bill, we have many, many items to address this cost of healthcare and to make coverage more affordable for people who are under or uninsured. So the first item we have is what's called the Health Affordability Board. And this is in Article 3, Sections 1 through 8. And the Health Affordability Board is an entity that evaluates the growth of healthcare costs over time, and it sets benchmark targets. Other states have implemented this, for example, Massachusetts, and they reduced their cost growth by $9 billion over 5 years. This is a real, should be a nonpartisan item, as states are adopting something similar to try to address the high cost growth in healthcare. And what they do is evaluate the costs over time of hospitals and clinics, of our healthcare providers. And they try to understand the drivers of the healthcare costs and how to address those cost growth with targets, but also work with providers on improving efficiencies and becoming less expensive. A second item in our bill is the Minnesota Care buy-in proposal. Minnesota Care, remember, is a program that's been around for over 30 years and was created with support from Republicans and Democrats in our state. And it's been a very successful program of providing health insurance coverage, access to healthcare at very affordable premiums. And this would allow, the language in our bill would allow people to buy in, pay the full premium, and buy into this very successful coverage program that is managed by private health insurance plans and private providers. It just provides subsidies if people qualify based on their income, but allows them to buy into that very good coverage that we've had for 30 years in the state. Other proposals that we have in our bill to address the cost of healthcare is an option to opt out of managed care Medicaid. And this allows people to stay in the fee-for-service program. And this is actually cost savings in our bill. Another item is to eliminate cost sharing from some of our public programs. This would make it much more cheaper to get the coverage they need. Another item is increasing the MA asset limit to help individuals who are older adults, 65 years of age or older, and people with disabilities. Another item is to have continuous eligibility for 12 months for children in our Medicaid or medical assistance program to keep our children covered, have access to good health care. All of these are really important items that helps families in Minnesota and children get the care they need and make sure that it's affordable for people, and helps people who are underinsured and can't afford those out-of-pocket spending by eliminating a lot of the cost sharing in some of our public programs. And another good item in our bill is the APCD, the All Payer Claims Database. This is a database that collects information from payers for healthcare, and what this bill does would also capture additional information. Right now, we're capturing information on claims data, what's paid by the payers for healthcare, by all payers. We also want to capture value-based payments, which is becoming much more popular as a way to pay providers and provide incentives for improving the quality and the outcomes from providing that care, patient outcomes. And this would collect information on what payers are paying to providers for these incentive payments or value-based payments. So we get a better picture, a whole picture of what's being paid for healthcare and our healthcare spending over time. So this helps us better understand the picture as we try to reform healthcare to make it more affordable. And so those are, I'm not going to mention all, we have many other items that address healthcare costs and affordability and coverage that I'm not going to mention, but I think it's our responsibility to make healthcare more affordable for people, because we're hearing people who are struggling to pay for healthcare, who are underinsured or uninsured. And it's really our responsibility to make sure we provide options for individuals to get the care they need, to make them more productive and continue their health so they are productive citizens in our state. So Madam Chair, that's all I have for today on healthcare cost summaries. So I'll turn it over back to you.
All right. Well, thank you so much, Representative Schultz. And, one thing I would add, and I have a particular interest in the cost barrier issue, usually called cost sharing, but I like to call it cost barriers, because oftentimes people have insurance But because of the cost barrier, the fact that they have to pay something out of their pocket, it often keeps people from actually getting the care they need. And a very uncomfortable statistic for us is that Minnesota actually has the highest out-of-pocket costs in the nation. The highest out-of-pocket costs in the nation. So I originally brought a proposal for discussion to just stop doing out-of-pocket costs. Well, naturally in the private market, this would raise premiums. But even in our public programs, we are putting barriers in front of people who are on our public programs. By definition, they are low income at the current time. And yet we require them to pay out-of-pocket costs to get the care that we are already paying for on their behalf. Does not really seem like a smart way to go, because we're paying for their care, and yet our programs are not really designed for them to get the care that they need. So, I think it is, I really appreciate Chair Schultz's work on this. And there are other things in this section, in this article also, that address this. And hopefully we'll be able to work with our counterparts in the Senate and hopefully work on some of these items and get some of them into the final conference report. Senator Abeler.
Well, thank you, Madam Chair. And I don't know we're going to have a big healthcare debate here, but I just thought I'd offer a few more ideas, not even to disagree so much. So if the issue is prices, you might ask, well, why are the prices so high in the first place? And you're thinking, oh, each unit is just so expensive, and maybe it is or not. But just to offer a few more thoughts, as I've been trying to grapple with this in my time. You and I and Representative Schultz have had many conversations. But just to add into the mix, that there's a lot of other elements, and I just jotted some things down off the top of my head besides prices, and actually things that create the prices being too high. And I think there's a whole bell curve of clinicians, and some always treat way more items per visit than their counterparts compared to the average clinician, which is actually about what things should be. The system really likes underusing providers because they are cheap. But there's inappropriate care, there's useless care, there's using the wrong clinician. There's some fields that are very effective at certain things and they're not always included. You have the old Jesse Ventura personal responsibility idea, which actually was one of his main benefits I took away from watching him be governor. And the failure of people to practice prevention. And what that gives us, as I don't even think we disagree in any of this, but I just want to remind people that's given us some of the highest costs in the world compared to our outcomes. And so, I'm all over helping with prices, but I think as we try to deal with actually helping be truly healthier, I think the benefit of the Obamacare thing was that people got to have a card in their wallet. Sometimes they didn't realize that it was $10,000 to use that card with deductibles, and that's part of your point, Madam Chair. You raised the point about that. But so I think we focus too much on having insurance and making it cheaper and not helping people be healthier. So I'll just leave it at that. So it's just my contribution for you. Thank you.
Thank you. Thank you, Senator Abeler, for those comments. But according to research looking at what's driving our healthcare costs, it's the biggest driver are prices of healthcare in this country compared to other countries. But the personal behaviors, they don't explain very much of the growth in healthcare costs or prices. So we have to look at those other factors of what's really driving prices. But when we have 22% of our population in Minnesota that are underinsured, and this has only gotten worse over time because family premiums are $15,000 to $25,000 per year in Minnesota. That's often more than 20 to 30% of a household's income. So this problem is only going to get worse if we don't tackle it as a state sooner rather than later.
Mr. Chair.
Yeah, thank you. And let's see. Oh, okay. Well, Representative Gomez has her hand up, and then we'll go to Senator Benson. Representative Gomez.
Thank you, Madam Chair. So I'm, unlike a lot of people here, I'm not an expert on healthcare, but I think that all of us have the experience of interacting with our healthcare, and it's extremely dysfunctional. And we need to talk about the fact that we have a profit-based healthcare or a profit-based insurance system in this country. And that's the big difference, is that we have, you know, the prevailing logic of the insurance companies and pharmaceutical companies is to maximize the extraction of profit from what is a really basic human need that everybody needs. So, you know, I mean, we have a health insurance industry makes billions of dollars. I don't know. I mean, I just Googled it. $30 billion a year in profit that gets extracted from our system. And so, you know, that the whole kind of the business model, and it is a business, unfortunately, even in our context where we have, you know, supposedly a nonprofit industry only allowed. Well, I mean, I know that changed in 2017, but is about denying claims of sick people and, you know, and creating, you know, mechanisms that are confusing and make it so that, you know, those of us who are navigating it, like, can't access the care that we need. So I guess I just wanted to say, like, I mean, I know that there's a lot of specifics, but the fact of the matter is that if you have corporations and shareholders extracting massive amounts of profit from something that is a basic human need, then that's how you get to where we are. Highest costs and worst care of anywhere in the world, in the developed world. So thank you.
All right, Senator Benson.
Thank you, Madam Chair. And we continue to have, and I'm so glad that Representative Schultz just called out, it's the prices that are charged, because that is usually not spoken of when we talk about the cost of healthcare, utilization and prices. And so, as I've stated many times, our public programs negotiate very low charges, allowable charges. And so the more we do that, the less money flows into the system. And I know some of you would really like less money to flow into the system. But before we start selling the panacea, let's make sure that our hospitals can survive and that physicians, nurses, chiropractors will agree to operate under the Medicaid rate or the Medicare rate. No one ever talks about what happens when you adopt those rates. And so if we're going to continue to have this conversation going forward, I would like testimony, and to those folks who are listening, MMA, I'd love a letter from you saying you're willing to accept Medicare rates for all services or Medicaid rates for all services. Hospital systems, as you're listening, please send this committee a letter saying you're willing to accept Medicaid rates across the board, because that's what these proposals will do. And so happy to have the conversation about prices, but the stakeholders who are watching this committee need to send us letters agreeing to take Medicaid rates across the board.
Thank you, Senator Benson, for those comments. The high prices is a problem for all payers, even those who have insurance through their employer. I mean, we see huge price variation, just keeping it on the private side in terms of those who have employer-sponsored insurance. It's a problem. And it doesn't make sense for one hospital to charge twice as much as another hospital for the same exact procedure. We have to better understand what the prices are, regardless of who's paying for the services. And I'll just mention that in Chair Liebling's bill, when people have ability to opt out of managed care organizations, our Medicaid program, there's a cost savings. We should probably ask ourselves, why is there a cost savings there? Are we overpaying for when these managed care health plans bid to cover our Medicaid population? Are we paying too much? Remember, a few years ago, UCare reimbursed the state $30 million because we overpaid for those managed care contracts. So what are we getting? What is the value for for what we're paying them. Are we getting the value back? We should really investigate that and maybe look at our competitive bidding process again to make sure we're getting the most value for having private health plans manage our Medicaid population. And then in the Minnesota Care Buy-in Plan, these are private health plans that are negotiating reimbursement with our private providers. So we can look at that negotiation and see what those reimbursements are. But I think that we have to worry about the prices across all payers, even those with private health insurance through their employer.
So, just as we did in our committee, I know we could have this kind of discussion for a very long time, and it's of great interest to a lot of us, but I would just say this. What we can't afford to do is nothing. Because I think we all recognize there is a problem. And we all want to solve the problem, although we all have different ideas perhaps about what the right solution might be. And it is true that states at a certain level have our hands tied. There are, states do not have all the tools with which to address the problem. Some of it has to come from the federal level, and some has, but obviously there's a lot of discussion about those solutions as well. But we can't do nothing, and we need to try some approaches. And so, we're not going to solve it here today in this conference committee, because this is obviously, and I know the public can see this, these are really complex issues. And the cause isn't all one thing. There are lots of things that feed into the rise in costs of healthcare, the fact that we have such a dysfunctional system, as Representative Gomez alluded to. I mean, even sometimes for people who, one would think would be in the best possible position to get care, sometimes it can be really a challenge to get care. It can be really a challenge to get the right care. And it can be really a challenge to figure out what you should be paying for that care. So we have a system that is so complicated that even people who should be in the best position often can't navigate the system to get the care. We have a system that is between the needs of people and the care. So, doing nothing really shouldn't be a solution. And even the one policy that Chair Schultz mentioned, the all-payer claims database, trying to expand it to collect some extra data. I mean, that doesn't do anything immediately, but one thing it does, it takes a step toward giving policymakers more understanding of what's going on in case there is policy that can be crafted to try to address some of these issues. So, Senator Abeler.
Well, I don't know how long you want to talk about this, but I'm kind of enjoying the conversation, but I'll be just very brief. And I just wanted to, I don't think we're debating. I think we're people having a discussion, and there is some place to be had there. But just one thing you said just provoked me to push the little hand up thing. I remember sitting in these very rooms in 2013 and 2012 with then Chair Huntley saying, we can't do nothing. And there was great optimism in Washington with the Obamacare thing, and that's not even meant to be a pejorative, but that was like the big thing that was supposed to make so much difference, and we have to do something, it's so broken. I'm sure you remember that rhetoric. And it turns out that in the effort to do something nice, we lost pretty much every affordable plan, because in Representative Gomez's point, I thought some of the, well, the word greedy is so harsh, but the, whatever. They just took advantage of getting rid of the loser plans, which actually were good for people, and they made some money on that. But they all disappeared, and now we have high deductible plans, and we're spending way more money. If you look at the ticket on everything, not just what the consumer pays, we're paying way more. And families are being priced out since the miracle of that came along. So I'm just going to caution everybody, you could make it worse, and as we talk prudently, let's keep doing that. So thank you, Madam Chair.
Thank you.
Senator, we've heard this a lot. First of all, I think that the Affordable Care Act, while not perfect, and I must say I was rather disappointed when it came along because it did so much less than what I was hoping we would be doing. But because it still depended on a system of insurance. And so it didn't do the reform that some of us hoped that it would do. But I think it's hard to argue after 10 years. It has saved lives. It has given people coverage who we hear all the time, it has saved lives and it has done a ton of good. Keeping kids on their insurance, on their parents' insurance till they're 26 has been a godsend. Letting people buy insurance who would have been not allowed to buy it. Now I know Minnesota had AMCHA and so on. Very few people have had access to that really. Minnesota tried to do some things other states didn't try to do. But we did have a system. I mean, you can look back with rose-colored glasses, but I think it was much worse. Did it solve everything? No, not at all. We need to go forward. We do need to go forward. And my own point of view is that having a system based on insurance, private insurance, is never going to fit. It's just not a fit for healthcare. It's just healthcare should not be based on private insurance. So the Affordable Care Act took what was a very dysfunctional system, tried to make it better, tried to make it work. But those plans that oftentimes that you're mentioning, that you look back and say, oh, well, at least there was something they could buy. The problem is it didn't cover anything. You would get sick and you would find that you didn't have coverage. So, therein lies a problem. The system of insurance does need to be regulated because people are not always in the best position to know. You don't know what you're going to need. That's the problem. That's why you try to get your risks covered. So, Senator Abeler, I know you want to respond, and then I'll let you do that, and then we should go on to the next portion, I think.
No, I just wanted to, I'm not sure we agree on the mechanism, but I think we agree on the goal, and I just, we could discuss this till 3:30, which I think would be fun, but anyway, I just wanted to thank you for the conversation, and we're all going to keep slugging away. We all do want to help people, and it's not even bad that we disagree on how we should do it, so thank you.
I just want to say two things, Chair Liebling. We had millions of people who were uninsured before the Affordable Care Act was passed. We made a lot of progress in covering more people. That was the goal of the Affordable Care Act, and Republicans had ample opportunities to repeal it. It never happened. It's more popular now than ever before, the Affordable Care Act, and it's allowed, and the premium subsidies that were rolled out during the pandemic have helped people stay on coverage. So it's been a lifesaver for so many families in Minnesota. But I think we do have a common goal, Senator Abeler and Senator Benson. We are so close to covering everybody in our state. Think of how much progress we have made, especially during the Affordable Care Act. We only have 4% of the population who are uninsured. We can get that down to 0. And I think our common goal, hopefully our common value, will be to make sure everybody has access to good health care.
Yeah, thank you, Representative Schultz. So, okay, so on the next thing that we wanted to talk about today is moving on to the next section, which is Article 6 of our bill, which is the prescription drug section. And I've got Representative Howard here, who's the author of one of the provisions in the bill, and he's one of our leads on prescription drugs. So I'm going to ask him to give a brief presentation about the Article 6, and welcome, Representative Howard.
Thank you, Madam. Thank you, Madam Chair, members of the conference committee. It's great to be here. And I think what I wanted to do first, as I was kind of scanning my Zoom screen and looking at the members on this conference committee, is just to express gratitude. The issue of prescription drugs is one that members of this conference committee in both bodies have worked together on, and we've achieved some really important bipartisan results on behalf of Minnesotans over the last several years, from nation-leading reforms to look at our pharmacy benefit managers that's already seeing results, to the price transparency law that we passed to get a better handle on the status of drug price increases here in Minnesota, and the Alex Smith law, which just a few weeks ago, we found out more than 1,000 Minnesotans used that law to get affordable insulin when they needed it. And I'm just grateful for the work that went in on a bipartisan basis to make progress. But what I also wanted to say is that we can't rest on our laurels and presume that because we've had these bipartisan successes that our work is finished in this arena. I know that both bodies are concerned about inflation, about rising costs for families and seniors. And there's no place where inflation has been more pronounced than in the price of prescription drugs. The average retail price of over 140 widely used brand name drugs have increased more than 300% over the past decade. And so this is clearly an issue for our constituents all across the state, and one that merits our continued bipartisan efforts to get this right and to make a dent and to make progress. And so the House bill includes a number of provisions to do just that, to correct what I would call a power imbalance, where the big interests in our healthcare system are not working in a way that delivers better prices and better results for Minnesotans. And so I'm not going to go through every provision because I'm not an expert on each one, but I wanted to mention a few of them that I think are important and pieces of legislation that have been discussed for multiple years, including Representative Morrison's Drug Affordability Board, which would give more power to Minnesotans and allow us to fight to make affordable prescription drugs a reality. The bill includes Representative Stevenson's price gouging bill, which would prevent the kind of abusive practices that we've seen where certain drugs may double or triple or even worse in price. This bill has Representative Schultz's provision that would prohibit PBMs and health carriers from requiring or preferring a more expensive biological product over a biosimilar. And lastly, I'll mention the bill I'm carrying, which would cap copay costs for insulin, asthma medications, and EpiPens, as well as cap the cost of medical supplies for these chronic conditions. And because the last one's my provision, I'll make a few more comments on it. Specifically, the cost of medical supplies is an issue that I think has been under-discussed in the issue as it relates to insulin in our diabetic community. I've talked to a lot of families that are now actually paying more for the cost of their medical supplies than they are for insulin. And this bears out with some data from the American Diabetes Association that found that 15% of people with diabetes who rely on pumps or CGMs have delayed refills or needed supplies during the pandemic. And for 70% of those, the reason is because of finances. I've talked to doctors that say that sometimes they'll prescribe a different method to managing a patient's diabetes because the cost of the CGM is too expensive. And that really should never happen. The cost and the terms of an insurance company shouldn't dictate treatment for someone. That should be between the patient and the doctor. And because of this problem, we're seeing worse health outcomes. If folks are using CGMs, they're getting a better handle on their diabetes, they're less likely to show up in the emergency room. And so this piece in the bill that would cap copays, one other point, when we passed Alex Law, we were the first in the nation to do so. And since several other states have followed suit and are looking at it. But actually, when we're talking about a copay cap approach, we're actually falling behind. 20 states across the country have passed those copay caps. Red states and blue states, Kentucky, West Virginia, Texas, Utah, to name a few. And so, I think it's time and we can do some work to make progress here. And just in closing, as we've done in the past with these provisions, I think they're ripe for engagement and for our work together to make progress. And I don't think that I or the authors of these provisions are naive, they're sort of take it or leave it types of proposals. We understand there might be questions. an engagement that produces compromise. But when you look at what's facing our constituents with the high cost of prescription drugs, we really owe it to Minnesotans to do that good bipartisan work we've done in the past and take action. And we have a great opportunity to do so. And so with that, I'd stand for any questions that I can answer, and I'm just grateful for the chance to touch base about this today.
All right, thank you so much, Representative Howard. Really appreciate that. Senator Abeler.
Well, thank you. I just wanted to kind of hark back when we really did some good work together in a successful way, which is actually, I think, the best way to go forward with all of this stuff. Representative Howard, and well, if I name names, I'll leave off a whole bunch of people, but we really did dig in, and it was a little harder than we thought. But we really had some good success, and I'm still kind of sorry there's some gaps about that. And it seems like the pharma people are still fighting that. Is that right, Representative Howard? They're still, is that right? They're still complaining about that? Went through suing or something?
Madam Chair, Representative Abeler, that is correct. The law is in effect and has been and has been utilized. And we're seeing the utilization go up, which I think does sort of speak to this still being a challenge for folks. But it is in the pharma industry group that represents multiple pharmaceutical companies is still in an active lawsuit. An original case had been dismissed, and then they had appealed it. And so that's kind of the state of play on that front.
Yeah, and Madam Chair.
Senator.
So it reminds me as a first grader, Sister Lauren, I was little and she had this seemed like a very long finger, and she would wag at us and she would call us nammy-pammies. And I didn't know what a nammy-pammy was, but I didn't want to be one. And when the pharma people were here, I said, please don't challenge this. You know, what are you thinking? You know, why don't you just keep your word about how you really want to help people? And I'll remind them again, don't be doing that. Sister Lauren would be very unhappy with you because she taught us how to play well together. And so just to generally comment, and I'm not going to go in the weeds on your PBM stuff, I'm a fan of all cracking down on a lot of that stuff. And I remember Senator Jensen worked with some House members and made some good progress, and I think Senator Draheim as well. And Madam Chair, I think the best way for all this to go forward is when there's at least there's some kind of a consensus point. And I know you have ideas and they're good ones, and but I think a lot of those need some more collaboration. And so when we did the insulin thing, there was strong bipartisan support. I don't know how much bipartisan support there was in your bill for these items here, but I think when we get to something where there's at least a third of the other caucus being interested, I think that we can really get somewhere. So that's just my encouragement, and still happy to fight the fight. And just wanted to remember back with the Representative Howard, that was really a happy moment. I just remember that. So thank you.
So, well, thanks, Senator Abeler. And I would just say that we know that prescription drugs are a crisis for many Minnesotans. I told this story recently. This just happened to me recently. I was waiting to pick up a drug in a pharmacy, and I just watched an older man go to the counter and be told that he needed to pay $500, and he walked away without the drug. And I'm sure this happens many, many, many times a day. People in our state who have insurance of one kind or another, who have been prescribed a medication, often it's a very important medication, they're walking away without it because they can't afford it. And so, you know, I know we all want to solve this problem, but and this kind of goes back to something that Senator Benson said when we were talking about healthcare costs in general. Sure, there are people who don't want to reduce the prices. That's the problem. We have a system that's extremely complicated. The ball is being hidden in the drug area. It's being hidden all the time. And we have hearings on these issues, and the different entities, the pharmacy benefit managers, the manufacturers, the health insurance plans, everybody points at everybody else and says, no, they're doing it. No, they're doing it. And they divide us. They use our, partisan divisions to separate us and keep us from doing things to the benefit of our people. Things that we all know we should be doing. They make it super hard for us. I just read recently in the NCSL, which for the public is an organization of state legislators all over the country, bipartisan organization, and they put out all kinds of materials. And they're talking about all the states that are wrestling with this. All the states are trying to, whether they're red states or blue states, everyone's trying to figure out how can we get our arms around this? And the problem again is that states have kind of a limited toolkit that we can use, but we got to use what we have, folks, because this is a crisis. And any one of us, this isn't just about poor people, rich people, rural, urban, anybody tomorrow can have a need for one of these expensive drugs for their very life. And are they going to be able to get it? Are they going to be able to afford it? That's something we are all concerned about. We've just got to join hands as we did, over the Alex Smith bill. But boy, that took a really long time, and we were able to make some progress. We could build on that progress and go forward and do something really good for Minnesotans, so that if they're not using one of those drugs today, they could at least have assurance that they or a family member, if they need it tomorrow, they could be able to get it. That would be a super important thing for us to do. And there are a lot of good provisions in this bill that we could build on. I do want to mention a couple things here that are sort of in a different bucket that are in our Article 6, just to make sure that they're mentioned. And I hope we'll work on these offline. I know many of us worked on the medication repository program that we authorized. And this has been pretty successful, and it needs long-term stable funding to be able to really fulfill its promise. And the Board of Pharmacy wants to contract with them. So this is a way that we can both provide cheaper drugs to Minnesotans who need them, but also keep waste drugs out of the waste stream. Drugs that can be reused and given to somebody else for free. And this is what they're doing. And I think it would be a great thing if we could build on that. And then finally, we have a very bipartisan effort in the intractable pain bill that is here. It needs just a little bit of work, but I think we're awfully close to an agreement on that. So I hope we can figure out, how to get people working on that and work out the little bit of disagreement or misunderstanding in the language between the two bodies and move that out, because I think that also would really help a lot of Minnesotans for whom intractable pain is making their lives impossible, and they need these really important drugs responsibly prescribed and managed to be able to control their pain and live a decent life. So I hope we can find some, time in this really abbreviated process to get that worked out. So thank you again, Representative Howard. So with that, I just want to move on briefly, unless there's discussion on this article, any more discussion before we move on? Okay. So we're pretty close to the end here. So I just did want to mention our Article 7, which is a few health insurance provisions. And again, this kind of goes back to, if you can have health insurance, but if your health insurance doesn't cover the thing you need, it can be like not having health insurance. And so we've got a few things in here. One is from Representative Poston, who brings back the ectodermal dysplasias coverage that I know we worked on a few years ago. And so probably many of you are familiar with that. I won't say any more about that, but except to say that those folks have insurance and they don't have coverage for something that is really impacting their lives. There's one from Representative Elkins to cover some lymphedema treatments and items, and that one, if I recall, has zero cost. There's one from Representative Acom about covering out-of-pocket costs for people who need a second mammogram. And then we have a provision from Representative Ryer that is the rare disease community is really, I think, putting a spotlight on how dysfunctional our system is, because we have an insurance system where everybody controls costs with networks, narrow networks, And sometimes people have an illness or need a diagnosis where that network just does not work for them. So if you have a network that doesn't cover the provider that you need to see, it's like not having care. So that's in here as well. So I just really wanted to mention those, and that's all I have for today. So we could probably just talk for a second about the roadmap here, Senator Abeler, and let me just say what I think we're doing, and then love to have you chime in as well. So after today, we're not gonna do these meetings every day. I think we have, the next one will be Monday, that's scheduled as a conference committee public meeting, and the House will have the gavel on Monday. And in the meantime, we're really hoping, I know that the Senate has, the senators have their convention, and there's a lot going on, but we're hoping that we can have offline meetings and start to really, we've exchanged some documents. We're just trying to narrow down what the issues are, and hopefully we can work together offline and try to get closer and solve some problems and really work collaboratively. So that's all I have to say right now. Senator Abeler, over to you.
Well, thank you. I just had a call come in, so I missed one of your sentences at the very end, but then I picked up the gavel thing. And so just so people understand how that came to be, with our convention, I'm trying to keep this all as collegial as it can be, and at some point we're just going to do work, and who holds the gavel for whatever work is not so consequential, but still to be polite. And so because our convention's on Friday and Saturday, the House was considering having a hearing on Saturday, and I requested that they not do that, please, on behalf of our convention. And then, so it just made sense to allow the gavel to stick with them for Monday. So I think that's, I think it's good for the people to see us working together and collaborating and picking all the right fights. And so we're going to be talking, I think, tomorrow, Representative Liebling, and if we can, I don't know, is it safe to say perhaps we can even adopt some language on Monday if we can get some of the easy stuff out of the way. There's things that are on the policy side. There's some things we have to talk about, and I think some of our concerns will be allayed by a conversation over the weekend. And there's plenty of discussion to have about the money when that finally comes. So hopefully that will be successful this weekend. And then we'll talk offline about some other schedules.
Right, and thank you so much, Senator Abeler. And I think that I agree. This, we're all trying to be collaborative. There's no way you can get a bill done like this unless you're collaborative, for one thing. But we really appreciate your attitude toward that, and that of all of the members on this conference committee. It's really been very good so far. And we're going to have to really buckle down and work hard to get, because we do have a lot of work to cover here and a really short time to do it. So we are definitely hoping that Monday we'll be able to, we're going to be able to be adopting language, and, we'll hope we'll be in a much further along spot by Monday. We're all going to work hard to get there. So
And
really
Madam
appreciate
Chair,
your partnership.
Yeah, and so let me just offer a thought, which I have not discussed with anybody, which probably makes it a little more dangerous. But it seems as next week winds on, we have a time constraint from 1 to 4, but we just might need some more airtime. And just as it's available in a way that makes sense for schedules, if we have to meet into an evening or come in the morning or something, and that's totally would be agreed upon. But I think that just so the public should be aware, this is the last week coming, and we have to pass the bill by 11:59 on Sunday, or there is no bill. And so, but things are going very well. I don't know how the other conference committees are doing, but I think that it's a week has gone by, Madam Chair, and we're still all getting along pretty well. So I'm pretty happy about that. So take it away, Madam Chair.
Yeah, thank you. Thank you for that. So, yeah, exactly. We have that really tight time constraint. So anything other members of the conference committee want to say before we adjourn here?
Madam Chair, in the interest of transparency, I should probably say what I put in the chat. which is just that clearly HHS is the best conference committee in response to Senator Abeler's comments. So I want to make sure the public is, we're not hiding anything. I put that in the chat and I've now shared
That
it
comment
publicly.
needs
Thank
to
you,
be
Madam Chair.
public, and I think it's just presumed, but it's good to say it because we all know.
Right. Absolutely. Absolutely. Okay. Anyone else? Other members want to comment before we sign off here? And
The headline,
And-
the headliner is Love Fest for the first
Yeah.
week. So I think that's
Right.
what we should be here. So.
That's right. That's right. And just so the public understands as well, you know, we do have this big time crunch here as we get to the end because we all also have to be on the floor. We also have to vote on other bills. We also have, you know, have to be in a lot of places. So hope folks understand that sometimes the stopping and starting is really just has to happen. So it works. And I do want to say too that, you know, it is quite possible that we won't hold public conference committee meetings like this every day, because I think we really want to shift to holding them when we have something, a product to talk about, or, you know, we're going to have to do a lot of the work offline just by the nature of the beast to get it done.
Oh, and Madam Chair, I think we should, I believe it's agreed, but if we don't hold the gavel's going to change kind of by meetings, not by day.
Yes.
And no one's going to unduly not meet, so, but that way
No.
we don't have to have a meeting just because we want to burn up our time or something.
Right. This is all by conversation and agreement, and that's how we've done it so far, and that's how we will continue to work. So thank you, everybody. With that, we are adjourned.
Have a nice weekend.
You as well.